about the case study. So in today's tutorial lectures, we will try to explain two different case study. Both the case study are related to the lung function abnormality. In the first case study, we will try to explain about the chronic obstructive pulmonary disease. And in second case study, we will try to explain about the restrictive lung disease, right? So both the conditions are related to the lung function abnormality. So at the very beginnings, let us start with the case. We'll try to find out what are the informations given in the case, and based on the informations given, we will try to diagnose provisionally, and after that or after provisional diagnosis, we will try to give proper justifications, right? Now let's start with the case 1. What are the informations given in the first case? A 65 years old male presents with a shortness of breath for the past 2 weeks. He has been suffering from these complaints for the last 2 years. It was mild and intermittent to start with, and it has progressed more significantly over the past 2 weeks. It is also accompanied by a chronic cough producing sputum, right? What are the other informations given? He has a 40 years history of smoking. On general physical examinations, pulse rate was 100 beats per minute, blood pressures 130 over 80 millimeter mercury, respiratory rate 30 breaths per minute, and temperatures is afebrile. Systemic examinations reveals rapid shallow breathing, mild supraclavicular recession, barrel-shaped chest, decreased breath sound, and expiratory wheezing. Pulmonary function test shows obtained value of forced vital capacity is 4.2 liter. Forced expiratory volume in the first second of vital capacity is 2.9 liters. The predicted values of FBC is 4.6 liter and FEV1 is 3.8 liter. Now, in this case, lots of informations are given. Our first duty is to extract the important informations that is helpful for the provisional diagnosis, right? Now, try to extract what are the most informations given, and based on the extractions of all those informations, we'll give the diagnosis. See, what are the informations, most important informations given? See, which one? 40 years of history of smoking, okay?
Suffering from short of breathness from past 2 years.
Suffering from this complaint for the last 2 years, as well as progressed more significantly over past 2 weeks, okay? Then, which one? Okay, chronic cough producing sputum,
barrel-shaped chest and sound.
Barrel-shaped chest and decreased breath sound, okay?
FEV1 value more than FEC.
FEV1 value is more than or less than? Less than FBC. This is obtained value, and predicted value, see, here FBC is 4.6 and FEV1 is 3.8. Means
decrease when COPD का case.
COPD का case है. Are you sure?
Yes, sir.
So what now? If you are sure enough that the case is related with the obstructive lung disease, then you have to give proper justifications, right? We have already extracted the most important information from the case. Now, yes, according to you, the provisional diagnosis is chronic obstructive pulmonary disease or COPD. Here, it's most likely chronic bronchitis, that is predominant one, with elements of emphysema. Now, what would be our proper justifications against the diagnosis, against the provisional diagnosis? Yes, we could say chronic cough with sputums for more than 2 years. is the most important characters, or we could say hallmarks of chronic bronchitis, right? Other than this, you can see shortness of breath, that is the progressive shortness, right? This is dyspnea, is again another important conditions that is related with the disease. Then smoking history, a long time smoking history, that is a major risk factor for COPD. Other than this, now you look into this part first. See, the pulmonary function test shows the FVC value, that is the predicted value, FVC, that is obtained one, that is 4.2 liter. The obtained value is 4.2 liter here, and for FEV1, the obtained is 2.9 liters. So what do you mean by FVC here? It is the forced vital capacity, and FEV1, it is the volume of air expired at the very first second of forceful expiration, right? So it is 2.9 liters. Now if you compare this obtained value with the predicted value, this is the predicted value, it is also given in the case. So in case of FBC, it is around 91% of the predicted value, right? Now if you see the FEV1s, it is around 76% of predicted value, right? Now based on the obtained value of FVC and FEV1, we can calculate the ratio of FEV1 over FVC, right? So if we calculate the ratio, what is the percentage of FEV1? That is around 69%. See, now this is again another important information that we have calculated. Now this value will compare with the reference value, right? If you see, if you compare this ones, it is below normal threshold, right? So which one is normal? It is normal, that is 70%. So here it is around 69%, that is less than 70%. This ratio, here the percentage is 69%. Which not meets the threshold value, it is less than threshold value. So it indicates the obstructive patterns. So the informations, here it is mentions these things, these are the part of the provisional diagnosis, and we can use this FEV1 FVC ratio also for the diagnosis purpose. Now other than this, we have some physical findings like barrel shaped chest, decreased breath sounds, expiratory wheeze, rapid shallow breathings, and mild supraclavicular recession. Now we have the different factors that is related with the disease development. Now we have to explain about the physiological basis of all those symptoms that are mentioned in the case, that are present in the patients. Clear? For example, you can say a chronic cough with sputums. So what is the physiological basis of this chronic cough and the sputum formations? Yes, if you see the physiological basis, there is a hypersecretions of mucus and airway inflammations occurs in chronic bronchitis, the most important one. See, chronic bronchitis, it is an obstructive type of disorders, and in this particular case what we have seen, there is a airway inflammation, right? Airway inflammations, and due to the inflammations in the airway, there is a hypersecretions of mucus. So this is the proper explanations or physiological basis of the formations of chronic cough with sputum, right? Now if you see the second sign and symptom, that is shortness of breath, why it actually happens? It is due to air trappings and reduced elastic recoils. If you see the most important properties of the obstructive lung disease here, due to the obstructions in the airway, air trapping takes place in the lung alveoli, right? So at the same time, air trappings also occurs due to reduced elastic recoils. There is a reductions of elastic recoils of the lung alveoli that causes the trappings of airs in the inner face of alveoli. That ultimately impairs the proper gas exchange, and for that purpose the patient needs to increase work of breathing. So this is what is the proper justifications or proper explanations of shortness of breath. See here, increased work of breathing. Why? Obviously, to maintain the proper gas exchange, the patient needs to breathe more efficiently, and for the efficient breathings, it needs more energy store. So, yes, increased work of breathing is required, and this increased work of breathing leads to shortness of breath. At the same time, you see the information was given about the respiratory rate. Here it is not the normals, it's more than normals, right? It is tachypnea. And why there is a higher respiratory rate? Obviously, it acts as a compensatory mechanisms, right? Now, another important information is mild supraclavicular recessions. So, what do you mean by supraclavicular recessions? If you see the basic definitions of supraclavicular recessions, it refers to the inward pulling of the soft tissue above the clavicles, that is the collarbone, during inspirations, right? And it is a type of accessory muscle. See, it is a type of accessory muscles that is used and sign of increased work of breathing. Here we have mentioned the persons needs to increase works for proper breathing. So to maintain that conditions, we need the involvement of particular muscles, that is the accessory muscles. And what is the locations of that muscles? That muscles actually involves the inspirations, and it is a type of soft tissues, and these soft tissues are inward pullings of that soft tissues occurs during inspirations. Now, if you see the chest shape, it is a barrel shaped chest. So I'll explain what exactly looks like the barrel shaped chest is. See, in these particular conditions, the most important changes takes place is hyperinflations of lungs, right? Okay, there is a increase in the volume of lung, right, due to air trappings. So lung hyperinflations may occurs that causes changes in the chest shape. So mainly there is changes in the anterior posterior diameters of the chest, right? And it is due to the air trappings, and it is also due to the reduced recoil of or elastic recoil of lung tissue, right? See here, this is the most important features. See the normal structures. This is the anterior posterior diameters of normal chest, and this is the transverse diameters. The subjects who are having obstructive lung disease, in their case there is changes in the anterior posterior diameters, right? So this is a barrel shape, it's a barrel chest, right, that I mentioned here. Barrel shaped chest, it is again another important indicators for the diagnosis of obstructive lung disease. Now, another important thing, there is a decreased breath sounds. Yes, so if during the measurements, if you measure the sounds in the basal parts of the lungs, you will find a specific type of sounds. So here in this particular case, air trappings and hyperinflations reduces the air movements in the alveoli that causes the decrease in the breath sounds. This is again another important clinical features for the disease diagnosis. Now, in the next question, it is asked, why might these patients have a barrel chest? Obviously, as I've already mentioned, a barrel chest is a classical sign of lung hyperinflations, and it is seen in a particular case like emphysema, and it is a type of chronic obstructive pulmonary disease. What are the most important changes takes place in the barrel shaped chest? So there is a destruction in the alveolar walls. At the same time, due to the destruction of the alveolar walls, there is a loss of elastic recoils of the lung alveoli, right? And it also promotes the air trappings in the lung alveoli, mainly during the expirations. So obviously, during if there is air trappings in alveoli during expirations, obviously it will reduce the expirations of airs. At the same time, it will increase the residual volumes, means there will be more amounts of airs in the lung alveoli because there is a disturbance in the expiration process. Now, another important feature to the viral chest is chronic over expansions of the lungs pushes the rib cage outwards. The chest takes on a rounded, that is bulging appearance as the anterior posterior diameters changes. That is, there is an increase in the anterior posterior diameters of the chest. This is the diameters, mainly the anterior posterior diameters, and mainly the anterior posterior diameters increases. So these are some important things, that physiological things that is related with the development of the barrel chest in obstructive lung disease. So in the next questions it is asked, what are the physiological derangements typical of this disease, right? So the most important one is obviously airflow obstruction, because it is a obstructive disease, right? So airflow obstruction is the most important one. So what would be the proper explanations about these airflow obstructions? Yes, due to narrowed and inflamed airways, and also due to the depositions of mucus called mucus plugging that prevents the proper flow of air during expirations. Now, another important derangement is air trappings and hyperinflation. So obviously, as I have already mentioned, air trapped inside the alveoli, and due to the air trappings, there is a increased expansions of the lungs called hyperinflations, and it is caused by loss of elastic recoils of the lung tissue as well as premature airway closes, mainly during expirations. One thing we have to remember that obstructive lung disease mainly related with the complications during expirations, not during inspirations. It is fully related with the abnormality during expiration. Now, the most important features or derangements or physiological derangements is reduced FEV1 as well as the ratio of FEV1 FBC. Now, see the case for normal subjects. If you see the time volume curve of FBC, of forced vital capacity, see from here, it is around 5 liters of little more from 5 liters for healthy subject, right? The FBC value for healthy subjects is around 5 liters, right? And if you see the forced expiratory volumes at the very first seconds for healthy subjects, it is around 4.8 liters, right? And if you compare the findings of normal subjects with the subjects who are having obstructive lung disease, there is a sharp reductions in FEV1 value, right? At the same time, there is a little reductions or reduced value of FBC. Still, we could say the FBC for both the normal subjects and the subjects who are having obstructive conditions are almost similar, slightly reduced. But if you compare the FEV1 value for both the healthy and abnormal subjects, you will find sharp difference. So this is again another important indicator for the diagnosis of the subjects. Using this, if you compare the things using the flow volume loop, this is again another important thing. This is called flow volume loop, right? The flow volume loop actually gives us a visual representations of air flow during exhalations. So it is again another important thing for the proper diagnosis. We not only depends on time volume curve, right? We also can compare the findings with the flow volume loop. It is a visual representations of the representations of airflow during exhalations. So if you see the normal case, In this particular case, you see, in a normal cuffs, the flow rate decreases as lung volume decreases, forming a relatively straight-sided triangle. You see, this is the triangular shapes. This part is basically inspirations and this is the expirations, right? This is the inspiration and this is the expirations. For healthy subjects, what we have mentioned here, it's relatively straight-sided triangles. But if you see the patterns of flow volume loop of obstructive subject, there is a concave shape or scoping. It means the flow during expiration, this is the expiration, the flow during expirations is less than the flow during expirations for healthy subjects, right? So this is what I mentioned here. There's a reduced FEV1, so this is the reduced FEV1, and at the same time, if you compare the ratio of FEV1 or FBC, it is also reduced. When we compare our ratio with the predicted ratio, it is reduced. So this is again another important hallmarks of obstructive lung disease. Now, other than this, some other conditions also mentions in the case that can be used for the proper explanations of this particular obstructive lung disease. Like you can see, increased work of breathings, and it is due to insufficient ventilations. Obviously, the ventilation rate is not sufficient for those subjects who are having such type of abnormality, and in this particular case, there is an involvement of some accessory muscles, recurring accessory muscle use, right? You can see, so decreased access tolerance, this is again another important derangements. So the proper explanations against this particular derangements is poor gas exchange and increased efforts limits. Increased efforts limits the physical activity. So up to this, we could say in this first case, whatever the informations given, the most of the informations are related with the obstructive patterns of the lung disease. Now, after extractions of all those factors, we use all those factors for the proper diagnosis, so called the provisional diagnosis, and we have justified about the diagnosis, and we have also explained a little bit about the different type of physiological derangements that is related with this particular disease. Now, in the first case, I hope the things are now a little bit clear. So, mainly 3 things we have to look after. One is the ratio, then whether there is any changes in the chest, or mainly the structures of chest, whether bell-shaped chest are present here or not. And at the same time, we also can compare the things with some other physiological, clinical parameters too. Now see, now first case is now clear. If you have any queries regarding the first case, you can ask. Okay, now let's move to the second case. As I've already mentioned, both the cases are related to the lung function abnormality. Obviously, this case is also related to the abnormality. Now you have to diagnose whether this case is related to the obstructive patterns or restrictive patterns. Now first read the case and then you just tell me what would be the provisional diagnosis against the information given in this particular case. A 60-year-old patient presents to the OPD complaining of shortness of breath for last 2 years. It was mild to start with, but has progressed over time and more for the last 2 months. Okay, this is accompanied by persistent dry cough, that has also worsened over time, right? There is no history of smoking, there is no history of asthma and other known respiratory illness. He has a significant occupational history of working in an asbestos processing factory for 25 years. Very important line. Work history is given. The person's work history tells that he works for long times in a particular factory called asbestos processing factory. Here he was involved in the handlings and cuttings of raw asbestos materials with the minimal respiratory protections. Means the level of respiratory protections for that particular workers is very, very minimum. Now some general physical examinations or informations related to the general physical examinations are: pulse rate 90 beats per minute, blood pressure is around 130 over 80 millimeter mercury, respiratory rates is 24 beats per minute, and sea temperatures, febrile and presence of clubbing. Now systemic examination shows rapid breathing, slightly reduced expansions of the lungs bilaterally, then fine, dry and inspiratory crackles on auscultations is again another important information is given. Know who is heard, chest as previously, and it shows reticular shadowings of the lungs peripheries and more toward the base. CT scans of the thorax shows irregular septal and pleural thickenings. Now, the subjects are advised for digital spirometric evolutions. Now first we will try to extract the most important information from the particular case. एस्बेस्टोस कंपनी में काम करते हैं इसलिए एस्बेस्टोसिस होने का चांसेस ज़्यादा, ओके, क्योंकि उसने बहुत ज़्यादा टाइम तक उस कंपनी में काम कर रहे हैं, ओके?
Exposure to toxin plus minimal protection.
Yes. It means the durations of exposures is very high and the protections, respiratory protections is very, very minimum. Okay. Another, what are the other informations?
Sir, crackling sound.
Which one?
Sir, crackling sound.
And inspiratory crackles on auscultations. Okay.
Sir, rapid breathing.
Which one?
Sir, rapid breathing, systemic examination.
Okay, rapid breathing.
Yes,
sir, dry cough.
Which one?
Dry cough, second point.
Second points, dry cough. Okay. So now,
sir, reduced expansion of lungs bilaterally.
Reduced expansions of the lungs bilaterally.
Sir, मतलब obstructive नहीं होगा, obstructive होता तो dry cough भी नहीं होगा.
This is important.
Sir, obstructive नहीं होगा, ये restrictive में आना, मतलब induced toxin हो तो asbestosis cases.
So asbestosis हो सकते हैं. So our provisional diagnosis tells that it may be asbestosis, right? Now we have to give a proper justifications about our provisional diagnosis. Now progressive dyspnea and persistent digraph. जो तुम बोले अभी तो this is the most important information that is given in the case, based on which we can say yes, it may be related with this restrictive pattern of lung disease. Now another important thing is clubbings and fine and inspiratory crackles on auscultations. So what is the meaning of this and inspiratory crackles? It means there is a specific type of sounds that may occur in this particular case, and it's mainly during the end of inspirations, right? And here clubbings. So it is the features of morphological changes. So you can see the most important symptoms of clubbing. These are some important symptoms of clubbings that may occurs during these particular conditions, like when the asbestosis develops, the clubbings may happen, like there is a bulging of fingertips, and And at the same time, if you see what are the other changes that may take place, worms and red fingertips and soft nail beds, as well as the downward curved nails. These are some important features that is related with the clubbings, and clubbings is the most important characteristics of which is related with the asbestosis development, right? Now, as I've already mentioned, this is an important point. Other than this, you already mentioned occupational exposures to asbestos for 25 years without proper respiratory protections. This is another important information. And now, other than this, the what are the informations given regarding the chest texture? Like there is a reticular basal shadowing. This reticular basal shading is mainly due to the thickening or the formation of some scar tissue or lungs scar tissue. This is called scarring of the lung tissue, right? So in this particular case, there is a high chances of the formation of scarring of lung tissue. So this scarring of lung tissue actually mainly involves with the formation of reticular or basal shadowing. Other than this, you can say CT findings. There is a irregular septal and pleural thickenings, and this irregular septals and pleural thickenings also known as the hallmark of asbestosis, right? See, there is no history of smoking or no history of asthma, and it further supports a fibrotic etiology over obstructive disease. See, here, what are the most important points that we should mention during the justifications of the disease is, obviously, uninspiratory crackles, obviously, dyspnea and dry cough. Other than this, long-term exposures of the asbestos, and along with this, the formation of scarring or scar tissue or scarring of lung tissue. These are the most important information which supports the disease developments, that is the asbestosis developments. Now, see what are the most important risk factors as already mentioned: chronic occupational exposures, lack of respiratory protections, and the duration of exposures, and advanced age. If you see the risk factors and their contributions, obviously chronic occupational exposures, direct and prolonged exposures to asbestos fibers, and especially raw asbestos. Now, here's the most important thing is the size of the particulate matters, right? In most of the case, yes.
Sir, clubbing.
Which one? Clubbing. This is actually, if you see the morphology of the clubbing patterns, as we know, this asbestos is particulate matters, and this particulate matters exposes lead to the fibrosis of the lung tissue. At the same time, whenever the asbestos gets trapped into the alveoli, it releases some cytokines from the damaged tissue, and it circulates across the body, and maybe this is one factor that may affect the periphery of the body. This may be one factor. Those whose diameter is less than 5 micrometers, these are respirable fibers, and as these particles are respirables, there is a high chances of the depositions of those matters in the distal airways as well as the lung alveoli.
Sir,
and
जो फाइबर से कम डायमीटर है, तो ये तो लॉन्ग टर्म में ऑब्स्ट्रक्टिव कर देगा.
in that case, we can say it may develop the mixed disorders. both obstructive and restrictive. There's a high chances of the development of mixed disorders. Now, if you see the size whose diameter is more than 10 micrometers, in this particular case, there's more chances of the developments of inflammations, and inflammations also affects the lung passage. And other than this, asbestos is not broken down easily. This is another important factor, and it leads to the persistent inflammations as well as the developments of lung fibrosis. So what is the most important information that is related to this asbestosis, or that is related with the restrictive lung disease? Actually, asbestosis is a type of restrictive pattern. So here's the most important thing is the formation of or developments of lung fibrosis. Now, what are the expected changes on digital spirometry? Yes, as we have already seen, in case of obstructive, there are some changes in the normal FVC value or FEV1 value. Now, question is whether same type of changes takes place in the restrictive patterns or not. So, what are the most important changes? Now you can see here. In case of restrictive lung disease, you see the normal case, the FVC value is more than the FVC value of restrictive subjects. Means there is a decrease in FVC value, normal FVC value. This is one. And not only this, if you see the changes of FVC during the first second of forced vital capacity, there is also reduced FVC. Here's both the things. One is the decrease in the FVC value in comparison to normals. At the same time, there is a decrease in the FEV1 value in the patients compared to the normal subjects, right? The same things that can be explained using flow or volume loop. So, what are the most important features of this type of restrictive disorders?
The ratio same that
Ratio is almost same, or in some cases you may find a little bit higher than normal. You can see what are the most important features. The lobe shifts to the right side. This is once you can see from here, there is a shift of the lobes towards the right side of the normal curve. And other than this, volumes are less than normal. All the volumes, like tidal volumes, you can say, there is a volume decrease. The most important one is FEV1 and FVC decrease in the populations. As I have already mentioned, the FVC decreased as well as the FEV1 decreased. This is the most important features which you can diagnose the subject. And if you compare the ratio, yes, the ratio is almost the normals, or in some cases you may find there is a little elevations of the ratio. So these are some important indicator or marker that is basically used to diagnose the restrictive patterns. Here in this case, it is useful for the diagnosis of obstructive case. Now, I hope the part is little bit clear. Okay. So this is just a very basic things. How we can extract the information from the case, and how we can utilize those informations for the initial diagnosis of the subjects. So after initial diagnosis, obviously we have to be very much confident about the proper justifications about the diagnosis. Okay? Okay. So I will not proceed to the next part. In the next class, I'll try to explain a little more about this type of cases.